Dr. Grummon is an assistant professor of general pediatrics and health policy in our department here at Stanford. I have had the pleasure of knowing Anna since 2012. She had just completed her undergraduate training at Stanford in human biology, and I was up at UCSF starting up some of my very first research programs and was looking for a research coordinator. And Dr. Janine Bruce, who's also in our department, introduced me to a collaborator at the San Mateo County Department of Public Health. And that person said, I have a person for you, and told me all about Anna, and I got to meet her. And she joined our team up at UCSF as one of my first research coordinators. And even back then, she was extraordinary. She was teaching me about research, even after just graduating from undergrad, and had a real gift for working with schools and other community-based organizations in the local area. After working with our team for a few years up at UCSF, she then went on to pursue her master's and PhD in health behavior at the Gilling School of Public Health at the University of North Carolina, Chapel Hill. After that, she also went on to Harvard, where she completed her fellowship in the School of Public Health there. After her fellowship, we were lucky to be able to recruit Anna to the Division of General Pediatrics in our department, where she leads the Stanford Food Policy Lab. Her lab employs rigorous methods, including randomized controlled trials, natural experiments, and simulation modeling to investigate how nutrition policies such as warning labels, beverage taxes, and food assistance programs affect dietary intake and health of children and adults. Her research has been funded by the National Institutes of Health, the Robert Wood Johnson Foundation, as well as others. She's the principal investigator, not only on an NIH Career Award, but she's also an investigator on R01 grants, including being a co-I on those grants as well. She recently received an NIH R37 Merit Award for her exceptional research performance, and she's published over 85 peer-reviewed publications in prestigious journals, including JAMA, the New England Journal of Medicine, Science, Nature, and American Journal of Public Health. But what I find truly remarkable about Anna is her commitment to translating her research into real-world impact. Her work has shaped nutrition policies in cities like San Francisco and New York, and has informed recommendations by the Food and Drug Administration, as well as international organizations such as the World Bank. Her work has also been featured in major news outlets, including the Washington Post, NBC, and NPR. She's received a number of national awards for her work, including the Jules Hirsch Innovation Award from the Obesity Society, and twice she's been named an emerging leader by the American Society for Nutrition. So with that, I would ask you to please welcome me in joining Dr. Anna Grummon, who will be discussing her work on using strategic science to promote healthy eating policies. Thanks.
Thank you. It's a real pleasure to be here and to be introduced by someone who's been a mentor for me for a really long time. So thank you, Anisha, and thank you all joining in person and online. I'm delighted to be here to talk about some of our lab's work on using strategic science to promote healthy eating policies. And recognizing that this is a diverse audience of clinicians, researchers, community members, and that you all bring distinct expertise, I thought we could start by zooming out and telling you a little bit about what motivates our lab to do this work, why I think it's relevant to be studying food policy. And I'm going to start by telling you about some diet-related diseases in childhood, some statistics that may not surprise you, but that really motivate us. The first is that 20% of children have obesity, a third of teens have prediabetes, and 10% of children have elevated blood pressure. So of course, as clinicians, you know that these are multifactorial health concerns, but we also know that diet is a key contributor to each of these. We also know that diet and health in childhood are important not only in the moment, but also as we look towards the future. So both diet and these health outcomes I just described track from childhood into adulthood, making childhood an especially important time for us to think about intervening to improve diet. Unfortunately, progress addressing unhealthy diet has been quite slow in the US. So this slide is showing you average healthy eating index scores in the US from 2005 to 2018. That's the most recent year for which we have data. And healthy eating index score is just a measure of overall dietary quality. It measures alignment with the US dietary guidelines. And it ranges from 0 to 100, where higher scores are healthier. And you can see in no year are we doing better than a 60 out of 100, which, having taught undergrads at Stanford, is like not a grade anyone is happy with. And despite a little bit of progress through 2012, we've actually seen some backsliding in the most recent years for which we have data. So this tells me that we need new strategies to improve diet in the US. We also know that diets are especially unhealthy among young people. So with the exception of 2 to 4-year-olds, we see that healthy eating index is lower for all child age groups and for young adults compared to the national average. Again, emphasizing the importance of thinking about interventions that especially benefit children and their families. So these are population level problems that are affecting millions of kids and their families in the US. And our lab thinks that population level problems can really benefit from solutions that are also delivered level, like public policy. So when we manage to pass public policy in this country, it can have benefits that reach entire cities, states, or the whole country. For that reason, the mission of our lab, the Stanford Food Policy Lab, is to help policymakers design and implement policies that improve diet and prevent disease. We study a number of different policy areas, including food and beverage labels, food assistance programs like SNAP, all the way through policies that might promote more sustainable dietary patterns. But today I'm going to focus we're going to do a little deep dive into just our research on food labeling policies. And we bring a specific approach to this work called strategic science that I'm going to walk you through. It's a framework developed by Christina Roberto and Kelly Brunel back in 2015. And it's a simple approach that's meant to try to narrow the gap between the evidence we create as researchers and the policies that ultimately get adopted. So that's the goal of this framework. And it has 4 steps. The first is to identify key change agents. These are people that have power or influence over the policies you care about or the issues you care about. So this might be lawmakers or regulators, but it might also be advocates who lobby those lawmakers or the media who can shape public opinion about policy. So you want to find out who those people are. And then you want to build a relationship with them so you can understand what are key research questions that they need answered before they're going to be willing to advance the policy you care about. So you build this reciprocal relationship to try to understand strategic research questions, again, that if we answer, we might be able to move policy forward. The third step is the one we're all most familiar with. It's actually conducting the research to address those questions. And then finally, and importantly, we also need to communicate our research results back to those change agents in a timely manner and in a format that is accessible and usable to them. And of course, this is easier to do if we've already built relationships with these change agents throughout our research process. So again, this is a simple framework. It's probably not blowing any of your minds, but we have found when we've applied it in our work that it has meaningfully shaped the direction of our research in a way that we think and hope has been impactful for policymaking. Okay, so today, to give you a little bit more of a deep dive into this approach, I'm going to do a case study of how we've tried to apply this strategic science approach to our work on food labeling policy. To do that, I'm going to give you a little history, a little landscape of food labeling policy in the US, and then we'll do a deep dive into 2 of our studies that use this approach, one about the impact of FDA's recent proposal to require a front of package nutrient label, and another on product reformulation and calorie labeling. I'll end by talking about some new applications we're exploring with this framework and a little call to action. All right, so starting with the landscape of food labeling policy in the US, what's going on with food labeling these days? So I just mentioned that progress addressing unhealthy diet has been slow in the US, and this has led researchers like me, as well as policymakers and advocates, to ask whether new food labels could be part of the suite of strategies we use to try to address diet. So of course, it's not going to be the only policy we need. These are big problems, but could it be one of the many tools we try to use to move the needle on diet quality? When thinking about new food labels, I think it's helpful for us to consider the status quo for food labeling in the US, which is the nutrition facts label. You're probably all familiar with this. It's been required since the mid-90s. It appears on nearly every packaged food in the US. It is a numeric label that is shown in small print on the back or side of product packaging. And unfortunately, we know from a large body of research that most consumers, including consumers with a lot of education, have trouble using and understanding this label. So that has led to growing momentum for requiring a new type of food label in the US. And this momentum really started with labels for restaurant menus. For example, in 2015, New York City became the first jurisdiction in the US, and maybe the world, to require sodium warnings on restaurant menus. These warnings look like these little salt shaker icons, and they do two important things. First, they signal when foods contain a high amount of sodium, actually a whole day's worth of sodium, so very high sodium. And they also provide a warning at the bottom of the menu that describe the health harms associated with high sodium intake. So high blood pressure, stroke, heart disease, that sort of thing. And these features make this warning really different from the nutrition facts label because these labels are interpreting product healthfulness for us. They're not just telling us how much sodium is in these pancakes. They're saying this is a lot, this is high, you should worry about it. And here's why, here's some of the health harms associated with high sodium intake. So rather than just giving us numbers, which is what the nutrition facts label does, they interpret those numbers for us, they give us some context as consumers. And the hope is that this makes these labels easier to use, easier to understand, sort of regardless of how much educational attainment you have. So the industry sued to block implementation of this law, as often happens, but the regulation prevailed, and it was implemented in 2016. And research has indicated that the introduction of this label was associated with a reduction in sodium purchased from restaurants of about 17%. So pretty meaningful behavior change from a pretty inexpensive intervention. In 2019, Philadelphia followed suit, joined New York City in requiring these sodium warnings. And then New York City led the way again in 2023 in adopting similar warnings for added sugar on restaurant menus. This policy, like the sodium warnings, signals when foods are high in added sugar. Enforcement began just a few months ago, and I'm happy to say our team has been partnering with the New York City Department of Health and Mental Hygiene to evaluate whether this policy has similar effects on sodium, on added sugar as we saw for sodium. So you can see there's really growing momentum for this type of policy. The success of these policies, both in getting them actually passed and in their effects on behavior, have led researchers and advocates to call for applying these interpretive labels, not just to restaurant menus, but also to packaged foods, which of course make up a large percent of what each of us eat day to day. And just last year, about a year ago this time, the FDA heeded this call, and they proposed a rule that would for the first time require labels on the front of product packaging in the US. So nutrition facts is on the back or side. This would be a front of package label. They call it the nutrition info label. It looks like what you see on the screen here. This is what they proposed. And at first glance, you probably think that looks a lot like the nutrition facts panel. It does, but there's a couple important differences. One is that it focuses only on saturated fat, sodium, and added sugars. So we're sort of narrowing our focus to just nutrients that most Americans need to limit. And the second is that it interprets nutrient content as low, medium, or high. So you can see it includes these little words on the side. So we don't just get the number, the percent of daily value that the product contains. We also know if that's an amount we should worry about, if it's a high amount, for example. So I mentioned that this is a proposed rule, and I want to take a quick second to tell you why that's important. So a proposed rule is a draft of a regulation that a federal agency publishes for public feedback. The agencies can then revise or withdraw the rule before making it final, and only the final rule has the full force and effect of law. So this means that we have a little window of opportunity when we know what agencies are thinking about doing. They've released a proposed rule, we know what they care about, but they haven't finalized it yet. So we have a chance to do research to try to inform their final rulemaking. We have this moment in time when we're privy to what they're interested in, but they haven't yet finalized the rule. So given that we're in this window of opportunity, FDA has not finalized this rule yet. Our team wanted to understand what are some of the key questions that need to be answered about the nutrition info label that might be able to shape FDA's final rulemaking in a way that reflects the latest and best science. So to do that, we turned to our strategic science framework, and we sought to identify key change agents and understand what questions they had about this label. Two important change agents in this process of finalizing the nutrition info label are, of course, the FDA, who have the authority to change the rule and finalize the rule, and then an advocacy group called Center for Science in the Public Interest, or CSPI, which is based in Washington, D.C., and does a lot of lobbying federally and locally, including on food labeling policies. They actually work quite closely with the FDA, providing them technical assistance, needling them, suing them from time to time. So they're another sort of key player in the nutrition labeling space at the federal level. So we met with folks at the FDA and at CSPI. We reviewed public documents that they had posted to try to understand what are questions they have about the nutrition info label. And these were the three that rose to the top for us. The first was, are these labels likely to improve public health? So of course, that's what we all care about here in this room, is improving public health. Are these labels likely to do that? A second question that was especially important to FDA is, do these labels improve consumer understanding? Do they help people at the supermarket understand which product is healthier, which cereal is better than the other? And FDA had really framed their proposed rule around consumer understanding, I think strategically and politically, because consumer understanding is often seen as a less controversial goal than changing behavior. It's a little less nanny state. And so they had, in their public comments about the rule, really emphasized this goal of promoting consumer understanding. So we think that second question is one especially relevant to them. And finally, given that they haven't finalized this rule yet, would other designs be better? Should they change course to maximize these first two goals? So with those questions in mind, we then wanted to conduct research to try to inform FDA's rulemaking, again, before they make this rule final. So that brings us to our first study deep dive. I'm going to tell you about some work we've done on the effects of the nutrition info label and other designs that the FDA might consider. Now, when thinking about how new food labels might improve public health, there's two pathways I want us to consider. The first is probably the one that comes to mind immediately, which is effects on consumer behavior. So changes about what you and I buy when we go to the grocery store. The second pathway is that these new food labels can also induce product reformulation. They can change the types of foods that manufacturers sell by incentivizing those changes. So this first study I'm going to tell you about focuses just on that first pathway on consumer behavior. And the objective of this study was to understand how the FDA's proposed nutrition info label and other labels it could consider affect, one, the healthfulness of what people buy at the grocery store, and second, people's understanding of product healthfulness, consumer understanding. Again, those two goals that we think FDA is trying to optimize for. To address this objective, we recruited about 5,600 adults, all of whom were the primary shopper in their household, in fall of 2024. The sample was relatively diverse. About 11% were Black, about 10% Latino, a third with less than a college degree, half with household income of less than $75,000 a year, and about a third were parents. The study adopted a randomized design. We randomly assigned these 5,600 participants to one of 6 labeling conditions. The first condition was a positive labeling condition, in which we put these endorsement positive labels on healthier products. And we chose to study this condition because it represents a little bit of the status quo for front of package labeling in the US, because these labels are really common in that companies commonly use voluntarily. So they're labels that promote healthier items, but don't label less healthy items. So you can see why companies would like them, right? They promote their good items without shaming their bad items. So these are quite common in the marketplace. We specifically chose these little guiding stars labels as our positive labels because these are a commonly used labeling system. They're used in about 2,300 stores in the US. Our second condition was the nutrition info condition, in which we applied FDA-style nutrition info labels across all of foods. Our third condition was a high-in condition, in which we applied FDA-style high-in labels on products with 20% or more of the daily value for saturated fat, sodium, and added sugars. These high-in labels are labels that FDA had studied in their research leading up to their proposed rule, but they didn't ultimately choose. So we knew it was within the set of things they would consider, but they differ from nutrition info in that they only go on foods that exceed these levels for high in these different nutrients. So they're kind of only on less healthy foods. Then recognizing that if high-in or nutrition info labels were adopted, they would likely appear alongside existing voluntary labels. We also studied the combination of positive nutrition info and positive and high-in. And finally, we studied something that we call spectrum labels, which are labels that rate foods from least to most healthy using grades or stars or different colors, and they're applied across all products. And we studied these because they're used often internationally. So they're used in places like France, Australia, and New Zealand. And there's a good evidence base behind their effects on behavior. Okay, so those were our 6 conditions. We then did something fun. We built a fake online grocery store. So of course, we'd love to put these labels on real online grocery stores, but retailers are not super excited about putting warning labels on their foods. So to overcome that challenge, we built our own online store. We called it Grocery Central. And it's basically a fully functional online grocery store, except that we don't actually ship products to anybody. So it has search, filter, and sort features. You can see a screenshot of the frozen pizza section in our store. And we populated the store with about 5,300 products across 6 product categories that are top contributors to unhealthy nutrient intake in the US. The images, prices, and nutrition information in the store were all scraped from a real online store. So we created basically a mirror image of a, Kroger.com or Amazon Fresh. So it had really the look and feel of a real store. But we could put our own labels on it because it was our store. So participants entered the store, Grocery Central, and they selected foods and beverages they wanted to buy. And the products all displayed labels according to participants' trial arm. So you can see the spectrum labels here in our cereal aisle. And then participants then checked out and the store recorded their selections. We had a record of what they had selected. After they completed that shopping trip, we had them complete a survey. And that survey included questions meant to assess consumer understanding. Specifically, we had participants view 2 products side by side and select the product they thought was healthier. They repeated this for those same 6 product categories, and the products again displayed labels according to participants' trial arm. The 2 outcomes we were interested in map back to those 2 strategic research questions. So first, we were interested in the overall healthfulness of participant selections, which was our primary trial outcome. And we measured this with something called the Ofcom Nutrient Profiling Model Score, which is just a measure of the overall healthfulness of a product. It's used by the United Kingdom in regulations about what foods can be advertised to kids. So it has some regulatory background. And it ranges from 0 to 100, where higher scores are healthier. The second outcome we were interested in was consumer understanding, which we operationalized as correctly identifying that healthier product in those survey questions. Okay, so looking first at the impact on healthfulness. This slide is showing you average Ofcom scores, average healthfulness by trial arm. So we can see in the positive arm, participants bought foods with an average healthfulness of about 58.5 on that 0 to 100 scale, so about in the middle. And again, we can think of this as sort of our status quo, our control condition. Unfortunately, we saw no improvements from the nutrition info labels, nor from the high-end labels, nor from the positive plus nutrition info, or the positive plus high-end. Where we finally see a benefit is from these spectrum labels that are rating foods from least to most healthy using these colors and stars. The improvement was about 2.4 points, or about a 4% improvement. That probably sounds quite modest to you. It certainly is. This is not a huge improvement. However, we know from epidemiological studies, that improvements in diet quality of this size of about 2 points on the Ofcom scale are associated with reductions in weight, metabolic disease, and cardiovascular disease. So if this sort of improvement were scaled across the population, it could potentially lead to meaningful changes in public health outcomes, even though it's quite modest when you look at this one study. We also saw that the spectrum labels outperformed all of the other labels. So they were better than nutrition info, better than high-end, et cetera. And we found no differences, no effect modification by parenthood, income, education, or nutrition literacy. So these different labeling systems aren't likely to widen or narrow disparities along these dimensions. Okay, looking next at the effects of these labels on consumer understanding. Here you're going to see the percent of the time that participants correctly identified the healthier product in those survey questions. So in the positive labeling arm, we see that they did that correctly about 63% of the time. So they're doing better than chance. It's good. And here we see a really different story than what we saw for behavior change. Here we see that all of the labeling conditions outperform our positive labels, our voluntary labeling system. And we see that some labels do better than others. In particular, the nutrition info labels, whether alone or in combination with those positive labels, are the best. They're significantly better than our second best group, which is the positive plus high-end and spectrum labels, which in turn are better than the high-end labels. So all of these are better than our status quo, but there's sort of a rank order among them. We also saw that the label effects were not moderated by parenthood, income, or education, but were moderated by nutrition literacy. And I'll show you what that means on this slide. So what we are showing you here is the same outcome as before. The percent of the time people are correctly identifying the healthier product. But this time I'm splitting it up by participants with lower nutrition literacy and higher nutrition literacy in the light blue and the dark blue, respectively. So you can see there's a gap between high and low literacy for all of our trial arms, but the size of that gap varies by what label people were exposed to. And in particular, the size of that gap was largest for the nutrition info, whether alone or in combination with the positive labels, a gap of about 14 to 16 percentage points. So the higher literacy are always doing better than lower literacy on consumer understanding, but that gap is largest for these FDA proposed labels. By contrast, it's smallest for our spectrum labels that are rating all products from least to most healthy. So All of these labels improve consumer understanding overall, but we're seeing some differences in how much they do that for people with lower versus higher nutrition literacy. Okay, to summarize, in this randomized trial, we found that spectrum labels improve the healthfulness of participants' grocery selections compared to both positive labels, our sort of voluntary labeling system used widely by industry, and compared to what the FDA has proposed. By contrast, the FDA's proposed nutrition info labels did not improve product healthfulness, which suggests that spectrum labels might be a more promising option for FDA to pursue if their goal is to maximize improvements in encouraging healthier purchases. By contrast, we saw the nutrition info labels improved consumer understanding the most, but also led to the largest disparities in consumer understanding by nutrition literacy. So we sort of have an effectiveness efficacy trade-off here with these labels. This suggests if FDA continues to pursue the nutrition info label and it's implemented, we might want special efforts, outreach efforts to help people use the nutrition info label, especially people who might be starting out with less nutrition literacy, so that way we could try to avoid exacerbating these existing disparities in consumer understanding. Okay, so the last step in our strategic science framework is to communicate these results back to change agents. And I want to tell you now how we've tried to do that. We've undertook a number of translation and dissemination activities, the first of which is that we submitted a number of public comments via the Federal Register. The Federal Register is a government website, a .gov website, where agencies post proposed rules and final rules, and where any of us can submit comments about those rules. So I want to put in a little plug for public comments. Again, anyone can comment, you, me, all of us. You just go to this website and you can upload a PDF or type in a comment. And something really important about these comments is that agencies are required by law to consider all of them. Excuse me. So this is a rare moment when we basically have a guaranteed audience with federal regulators. They have to, by law, read our comments. So it's an important opportunity, I think, especially as clinicians and public health professionals, to make our voice heard. We also know that the industry often submits many comments on regulations that are likely to affect them, making it even more important to balance out industry views with, again, views from public health and medicine. So we submitted a number of public comments about the study I just showed you, as well as other research we had done on front of pack labeling. And we also organized to present our research findings in briefings at the FDA and in presentations to advocacy and research groups we knew were working on these labels. And these presentations were easier to organize because we'd already developed relationships with these change agents throughout the research process. So we sort of we knew who to talk to, they knew about what we were doing, et cetera. All right, so that was a lot of information about how nutrition info labels might change consumer behavior. I want to turn next to the other pathway through which labeling policies can improve public health, which is through changes in the food supply. I think this pathway is especially important for us to consider here in the pediatrics department, because changes in the food supply can make all foods a little bit healthier by default, which then means it's easier for children and their families to automatically eat healthier, even if they're not noticing or using new food labels. So this is sort of a win for us without having to rely on behavior change. With that, I'm going to tell you about another study which focused on the effects of calorie labels on product reformulation. As some background, you might be wondering, why are we talking about calorie labels? I thought we were talking about FDA's front of pack labeling policy. And you might imagine that it's challenging to study how new food labels affect the food supply before those labels are implemented. So nutrition info labels are not on the front of pack yet, right? They're still a proposed rule. So it's hard for us to know how manufacturers would respond to them before they're implemented. Instead, we can look to other food labeling policies and ask, how do those policies affect the food supply? And that might give us a guess as to what nutrition info labels are likely to do. So that's what we're going to do here. We're going to talk about calorie labels, and we're going to talk about calorie labels specifically for something that we in public health nutrition call prepared foods. So prepared foods are foods that are made away from home, that are ready to eat, and that we usually eat on site or soon after purchasing. Unfortunately, we know that these foods remain a public health concern. They account for about 1/3 of our total calorie intake. That's true for both kids and adults. And compared to foods that we make for ourselves at home, they're higher in saturated fat and sodium, lower in fiber, iron, and calcium, and served in larger portions. So they're thought to be a key contributor to diet-related disease in the US. For these reasons, policymakers have sought policy strategies to reduce consumption of prepared foods. And one strategy they've tried is requiring calorie labels for these foods. So we've had calorie labels on packaged foods for many years, since the mid-90s, that's the nutrition facts label. But until recently, there was no similar requirement to also provide calorie information for prepared foods. That changed with the passage of the Affordable Care Act, which among a lot of other provisions, as you might remember, also includes this requirement that food retail chains with 20 or more locations post the calorie content of their prepared foods. And this policy applies to fast food restaurants, to full service restaurants, and to supermarkets that sell prepared foods. You might be wondering, why are we talking about supermarkets? Well, it turns out that they're actually a growing and important source of prepared foods in addition to restaurants. More than 90% of supermarkets today sell prepared foods, and sales of supermarket prepared foods are growing faster than overall supermarket sales and than restaurant sales. So these are actually a growing source of where we get prepared foods in the US. Unfortunately, we also know that prepared foods sold at supermarkets are not any healthier than restaurant foods. So just because they're sold at the Whole Foods hot bar, they actually are quite similar nutritionally to what you would get at a restaurant. But no studies had examined how supermarkets responded to this calorie labeling policy. Did they change the types of foods they sold once they were required to disclose calorie content of those foods? So the objective of this next study I want to tell you about is to try to understand that behavior, that potential reformulation. In particular, we examined changes in content of supermarket prepared foods following the implementation of these mandatory calorie labels. To do this, we partnered with 2 large supermarket chains with whom our team has a long-standing relationship. These chains are comprised of about 1,200 stores located in the Northeast, Mid-Atlantic, and Southeastern US. And they both implemented calorie labels for their prepared foods in April 2017 in anticipation of the federal mandate. The chains provided us with data on the products that they sell, including nutrition information on those products. In total, they provided us with 8 time points of data, 8 repeated cross-sections, each of which contained a census of all the products sold across the chains. So this is basically a snapshot in time of every product on the shelf in these chains for these 8 different time points before and after calorie labeling. In total, this included about 480,000 observations from about 90,000 unique products. And for each of these observations, we had nutrition information about the products for sale. We took that data set and we split the foods into prepared foods and comparison foods. So prepared foods are foods that are subject to these new calorie labels that supermarkets now newly need to disclose calorie content for. And you can think of foods at supermarkets like fresh baked muffins, hot pizza, and items sold by weight at the hot bar. So prepared foods that are getting our new intervention of calorie labels. We then identified comparison foods that were similar to these packaged foods, but that were not subject to the new calorie labels because they were packaged, they already had nutrition facts labels. So think of foods like packaged muffins, frozen pizzas, and meal kits. So similar to our prepared foods, but they don't get this new intervention. We also stratified these foods into 3 different food groups that we hypothesized might respond differently to the calorie labeling law. We might see some differential product reformulation. We look specifically at bakery items like muffins, entrees and sides like rotisserie chickens, and deli meats and cheeses like sliced turkey. And these comprise most of the prepared foods that chains sell. Our analyses focus specifically on the calorie content per item. So we're going to ask, do items get less caloric after chains are required to disclose calorie information? And we focus specifically on what we call common items, which are items that are available at all 8 time points in our data set. So these are items that you can think of as more core to the supermarket's business. They're on the shelves quarter after quarter, year after year. They're kind of always there. So we focus specifically on those because changes in calorie content of those items represent true reformulation. We're changing an existing product. And again, they're more core to the supermarket's business. The analyses use what we call a difference in differences approach, which means we're going to compare change from before to after labeling, so change over time, for prepared foods that get our calorie labeling intervention, to change over the same period for comparison foods that don't get the intervention. So do the foods that get the intervention change in some way that's different than underlying trends in the comparison foods? And I'll show you what that looks like graphically. So what you're going to see on the next few slides is calorie content per item, with prepared foods shown in the orange triangles and comparison foods shown in the blue circles. So you can see in the pre-labeling period, the prepared foods are a bit more caloric than the comparison foods. And in terms of trends, both prepared and comparison foods are largely stable in their calorie content over this pre-labeling period, as you can see with the dotted line. And then when we examine changes from pre to post labeling, we see that prepared foods drop in their calorie content relative to what we would have expected if those trends had just continued forward. While the comparison foods really track very nicely with their trends, right? The dotted line is right on top of the cell. So this is to say that bakery items have fewer items after calorie labeling than what we would expect, where the comparison items don't. This gives a difference in differences estimate, which is an estimate of the effect of calorie labeling policy, of -8 calories per item. So this is a very small reduction. This is a 0.5% reduction in the calorie content of these bakery items, but we are seeing this evidence of very modest reformulation. By contrast, we do not see evidence of reformulation of entrees and sides. If anything, they get a little bit more caloric, though not significantly so. And likewise for deli items, we do not see evidence of reformulation. But kind of the big picture is that these common items are not changing very much after calorie labels are required. Okay, so the common items aren't changing, which might make sense. Consumers have expectations about how these items are going to taste. We also looked in exploratory analyses at items newly brought to the marketplace, asking whether companies might introduce lower calorie items once they're required to disclose calorie content. So just try to give consumers more options, including more low calorie options, again, once they're required to post calorie labels. We looked at these in exploratory analyses because there's just many fewer of these items. So our sample size is smaller. You're going to see our confidence intervals are much wider. But we did this using a similar difference in differences approach. All right, so what we found is that the median prepared bakery item introduced after labeling contained about 440 fewer calories than the median bakery item introduced before labeling. So basically, companies are introducing lower calorie items after labeling compared to what they introduced before labeling. And this is, again, net of changes in comparison items. This is actually a pretty big reduction. This is about a 27% reduction compared to the pre-labeling median. So we're seeing a lot more movement in the calorie content of these new items. We again see the opposite direction of association for entrees and sides that's not statistically significant, and a reduction in the calorie content of deli items that is also not statistically significant. But overall, again, a lot more movement in these new items about which consumers don't have expectations yet. We've also done similar analyses in chain restaurants and found a very similar pattern of results, where we see small changes in the calorie content of common items. You can see these are tracking really stably over time, coupled with larger reductions in the calorie content of new items, in this case, about a 25% reduction. So a similar pattern of results when we're studying how supermarkets respond to this policy and how chain restaurants respond to this policy. So this natural experimental evaluation found that calorie labeling for prepared foods might encourage reformulation for some product categories, especially bakery products, especially newly introduced bakery products, which suggests that the benefits of calorie labeling policies might extend beyond their effects on consumer behavior. If we're removing calories from the food supply, this can benefit consumers even if they're not using or noticing calorie labels. However, the lack of beneficial product reformulation in other categories suggests that we might need additional policies if our goal is to really spur this type of product reformulation. And I'll just note, thinking about the nutrition info label that the FDA has proposed, that it's possible that this label will be better at incentivizing reformulation than calorie labels, because this label uses thresholds to apply the designations low, medium, and high. So if you think back to that early slide when I showed you the picture of the nutrition info label, it interprets saturated fat, sodium, and added sugar content as being low, medium, or high with defined thresholds. And these thresholds give companies incentives to reformulate to be just below the threshold where they might have to display a high-end label, for example. So if you're selling potato chips and you are just above the threshold for a high-end label for sodium, you really want to take out a little bit of sodium from your potato chips so you don't have to put that high-end label on your product. So, and by contrast, calorie labels are applied linearly. They don't have this sort of threshold effect. So I think it's possible that if the FDA pursues nutrition info labels, we'll actually see more reformulation than we saw for calorie labels. And we did see some for calorie labels. So I think that's probably good news. All right, so to bring these two studies together, I've presented research today that has suggested that new food labels can improve the healthfulness of what we buy at the grocery store and promote understanding of product healthfulness. But the label design really matters. It matters whether we do a spectrum label, a nutrition info label, or a high-end label. I also showed you evidence that new food labeling policies can spur product reformulation, which in turn could amplify these demand side, these consumer side benefits of labeling policies. So with that, details about food labeling policy, I now want to tell you a little bit about how we're trying to apply the strategic science approach to other domains. So these methods apply not just to studying food, but also to studying lots of policies. And in particular, our team is now trying to bring our expertise in studying food labels to studying labels in other contexts, including studying warnings for social media. So it will come as no surprise to you that on average, teens and young adults spend a lot of time on social media, about 3 to 5 hours per day, and that heavier use is associated with a number of negative health outcomes, including depression, negative body image, poor sleep, et cetera. And this has led to calls for policy change, including in 2024, the US Surgeon General calling for warnings on social media. So he did this in an op-ed published in the New York Times, and it was a rare instance in which a policy proposal gained rapid bipartisan support. So in the months after he published this op-ed, more than 40 state attorneys general, both in red and blue states, agreed with this proposal, endorsed this proposal. And in just the 18 months since he published this, we've now seen 4 states adopt policies requiring warnings for social media, and that includes here in California. So these policies are all the way through the legislative process. The governors have signed them, they're on the books. None have been implemented yet. Most have effective dates into 2027. This suggests the growing momentum for applying this policy of warnings that we've used for cigarettes, we've used for alcohol, also now to the domain of social media. However, there's actually a lot we don't know about social media warnings. It's an area that has not been well researched. And in particular, we don't know what the warning should say. So the policies that have been passed, with the exception of California, only say that there should be a warning. They don't tell regulators what that warning should say. And as we know from our food labeling work, it really matters how labels are designed in terms of how they affect behavior. So it's not yet clear what health harms these should talk about. For example, should they talk about depression or negative body image? What would most motivate young people to reduce their social media use? So this is a time when we thought our strategic science framework can really apply well here. This is a moment when we can identify change agents and try to conduct strategic research to inform these policies while regulators are figuring out what these warnings should say. So the objective of this pilot study I'm going to tell you about in just a couple of slides is to identify promising warning topics for reducing social media use. To do that, we started by creating 6 different warnings about 6 different topics. So a warning about depression, a warning about negative body image, et cetera. And we identified these topics using our strategic science approach. So we reviewed state warning bills to see what sort of health harms they were interested in. We met with legislative staffers supporting the sponsors of these bills, again, to try to understand what was on top of mind for them, what was interesting and potentially relevant. So here's an example of a few of the warnings we created, one about depression, anxiety, one about body image, one about social media being addictive. And then we also created what we call a voluntary warning, which used language that was used by TikTok in a campaign that they did to try to discourage overuse of TikTok. So TikTok hired content creators to put these little posts in your feed that said, hey, you've been scrolling for a while, maybe take a break. So a voluntary warning that doesn't talk about health harms, but is meant to reduce use. Just wanted to see how these potential mandatory warnings would compare to what industry might be willing to do on their own. And then we created a control message to provide a reference point against which to compare these new warnings. We then recruited 1,000 teens and young adults just about a month ago in December 2025. So these results are hot off the press. And we had these participants rate these different messages on how much the messages discourage them from wanting to use social media. We call this perceived message effectiveness. And it's a simple way to try to gauge the likelihood that a message will change behavior. It turns out that it's sensitive to differences across messages, but also predictive of behavior change. So it's really nice in this context when we're comparing a bunch of different messages to one another. Okay, so this slide is going to show you the average ratings across the different messages that participants saw. And I want to point out 2 things. The first is that all of the warnings did better than control, including our voluntary warning and all the potential mandatory warnings. So that's good news. And the potential mandatory warnings all did better than that voluntary warning that TikTok is using on its own without regulators getting involved. So this tells me that policymakers have a range of options for what they might include in their mandatory warnings. That's good news. If a policymaker is really excited about a warning about sleep or negative body image, that's going to work better than nothing, as is a message about depression or mental health harms to children. We also see that the mandatory warnings are better than the voluntary warning, which suggests the importance of regulators passing and implementing these laws rather than only letting industry sort of self-regulate, use with their own voluntary messages. So this is, I think, an exciting moment for our team as, big states like California and New York implement these policies to continue to try to conduct our strategic science research to inform these policies. All right, I want to end now with a brief call to action. I want to encourage you to think about how you can apply a strategic science framework in your own work, regardless of whether you're a clinician, a researcher, or a community member. And the good news is that there are many ways to contribute to closing the gap between evidence and policy. Again, regardless of your role or background. Anyone can meet with change agents to try to inform your research, whether you're the one conducting the research or you're collaborating on it. And again, these change agents might include lawmakers and regulators, but might also include advocacy groups with whom you already interact, or they might include the media who can shape public opinion about public policy. And then even if you're not someone that conducts research, you can also communicate with change agents about research evidence. Again, you can do this through public comments, which federal agencies are required by law to read. And you can also give public testimony at school council meetings, city council meetings, et cetera. This is a photo of my colleague, Jim Krieger, testifying at the Seattle City Council about the Seattle beverage tax. In many instances, anyone can submit public testimony. You can write to your lawmakers, and you can publish op-eds and perspectives in venues where key change agents are likely to read them. So I'll end by reminding you the statistics that motivate our group to conduct the work we do, even in the face of strong headwinds against evidence-based policymaking. Now, the statistics and stories that motivate you in your work probably differ, but I hope you'll agree that whatever issue you care about, it's crucial for us to keep investing in conducting evidence-based policymaking to improve health of children and their families. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.